everyone.
अभी नहीं अभी डॉक्टर नीतू भी वेट काउंट डाउन ये दे रहे हैं ना so good evening everyone. I welcome you in another very informative webinar of UP State Ophthalmic Society. And today we have very brilliant faculty lined up for this webinar, and from all over the Uttar Pradesh, and in fact from West Bengal also. So we have Dr. Indraneel with us, who is from Sitapur and doing excellent work in vitreoretina. And we have Dr. Atul Dhawan from ASG Hospital, Kanpur, again a wonderful vitreoretinal surgeon, and he will be presenting his take on macular hole surgery. Then we have Dr. Anurag Kashyap from Varanasi, and he is going to present another very interesting case and very brilliant surgeon. We have Dr. Anchal Tripathi from West Bengal, and I am proud that she is our student also, and she is Colonel and doing excellent work over there. And then we have with us the moderator of this program, Dr. Neetu Vashne from Muradabad, very brilliant surgeon and very enthusiastic ophthalmologist. And also, she is a scientific committee member, very active scientific committee member. So, I welcome Dr. Neetu Vashne. I also welcome Dr. Anil Srivastava, sir, who is co-chairman scientific committee and always very active and encouraging us to bring new ideas. Soon we will be joined by Dr. Shashank Kumar sir, who is the president, and Dr. Abhishek Chandra, who is the secretary. And both of them are dedicated to bring UPSOS on the national and international platform. So with this, I would ask Dr. Neetu Vashne to moderate this session.
Thank you, Dr. Shalini. It's indeed a great pleasure to moderate this session, and I'm watching you since the I became the member my scientific committee, and you are organizing this webinar regularly every month, and many interesting cases and many experienced speakers speak on different, very important topics which benefit us a lot. So today our first speaker is Dr. Anurag Kashyap. He is MS Gold Medalist, FIOL, FAICU Consultant Anterior Segment Services, Chakshudam ASG, Varanasi. Today he is presenting a very important topic, precision in crisis from PCR to optic capture. As we know, PCR is a very common complication, and even it happens in the best hand also. So I today he will give a very important insight how to manage a PCR and how to do the optic capture of IOL implant. So I invite Dr. Anurag Kashyap to present his talk.
Am I audible, ma'am? Is my screen visible?
Yes.
Okay. Very good evening to all. Am I audible, ma'am? Shall I start?
Yes, definitely. Go ahead, Dr. Anurag. You're audible.
Yes, ma'am. Thank you. Very good evening to all. Thank you, Shalini ma'am and UPSOS for giving me this opportunity. I'll be presenting a case where a complication occurred during the hydroimplantation of the single piece IOL. So the surgical demonstration goes like this. So, at the time of PCR, which was noticed during the hydroimplantation, the lens, which was a single piece hydrophilic IOL, was lying in the anterior vitreous phase. So pathophysiologically, what is happening here is PCR, which leads to a loss of posterior capsular support, migration of vitreous anteriorly. So here the lens was not supposed to be placed in that sulcus. So patched vitreous is being taken care of here. The vitrectomy probe, we are using a high cut rate and low vacuum to address the prolapsed vitreous through the incisions. As you can see, it is done under the direct visualization. Here, you can also notice the peaking of the rhexis margin, which was taken care of by the vitrectomy cutter. Enlarging the incision, the main wound, in order to explant the IOL, we need to enlarge that incision. A dialer is used for counter traction, while simultaneously the Vanage scissor is used to cut the IOL optic through and through. This is done to minimize the disturbance to the surrounding intraocular structures and for easy removal of the IOL through the main wound. Both the halves are being explanted. So this step we are showing loading of a 3-piece IOL. Note how the receding haptic of the IOL is being kept outside of the cartridge. This is a Alcon type B cartridge where the 3-piece IOL is being loaded first under visco, and then cartridge is being fitted into the prolapse. This also note the smooth movement of the IOL. During the implantation of the 3-piece IOL, we need to take care of the leading haptic being opening in or around the sulcus or in the anterior chamber. And then after that, the IOL is being implanted into the sulcus using the dialer. The 3-piece IOL, the haptics are being made of PMMA, so they'll provide a long-term stability to the IOL. Notice here how the optic capture of the IOL is done, which is shown by the ovalization of the rhexis margin. The rhexis margin, which previously was circular, after the optic capture, you can see clearly how it is getting oval. Important to note the maintenance of the anterior chamber. The AC is being kept firm. In case of a vitreous prolapse, although we have done a thorough vitrectomy, but we are closing the main wound by 10-0 nylon. Optic capture ensures the long-term stability of the IOL, and the case was closed. This picture shows the ovalization of the optic rhexis margin around the optic. Thank you. Thank you for your patience hearing.
So that was wonderful case, Dr. Anurag Kashyap. And you very rightly pointed out that sometimes during hydroimplantation, PCR can happen. And so at this juncture, we need to discuss that where should we not attempt hydroimplantation of IOL. So what would you suggest? What are the scenarios?
Ma'am, so this case was done during my earlier days where this PCR happened. The point being, we need to have a formed AC. If we are putting it in a AC where corneal folds are AC is not that well formed, or you can notice corneal folds present there, especially for a hydrophilic IOL, the force is enough to disturb the PC. The amount of PCR which happened, had it been made earlier, the IOL won't have stayed even in the anterior vitreous phase. For example, if the PC rupture had happened during the phaco, it must have it might have disturbed the vitreous so much so that IOL won't have stayed in the AVF. The hydroimplantation PCR usually the vitreous phase is initially it is intact. So you need to see for the PC folds, are there multiple folds to identify a PCR in its early stage. Regarding your question, ma'am, where not to try this, if the patient is not that well cooperative, or you are having any difficulty to keep the eye in primary position or in control, we should attempt it under the visco.
Very rightly said, Dr. Anurag. And once it happened with me also, I did a posterior polar and it went off very smooth. But after that, I forgot that it was posterior polar. And I started doing hydroimplantation in that. And then I had that PCR in that particular scenario. So, otherwise, hydroimplantation is extremely good technique because it fastens your surgery. And then there is no residual viscoelastic also. So, there is no post-operative rise in IOP or reaction and everything. So otherwise, you managed it wonderfully well. And in fact, the optic capture part was very nicely done. And moreover, you have implanted three-piece IOL that it in itself says gives a message that never implant the single piece IOLs in sulcus because later on they can create problems. So always
Yes.
implant a three-piece IOL. And you showed the loading also very nicely. How we should the posterior haptic should be put side and in that groove in back of the notch so that it doesn't get stuck and doesn't break during implantation. So I think
Yes,
it
ma'am.
was really very wonderful case. Thank you
Yeah.
so much, Dr. Anurag.
Yeah, so just adding on to that, ma'am, the hydrophilic ions, they are not supposed to be placed in sulcus. They're haptic. They would be, if at all they are placed, one first things first, their stability is not guaranteed. They'll be creating the thicker haptics would be disturbing the iris. For long run, there will be a chance of UGH syndrome. Then contradictory to that, like the three piece IOL, they are the haptics are being made of PMMA, so they'll be not they are relatively thinner. They won't be rubbing the back of the iris that much, and they'll be providing a long run stability to the patient, as if normal single piece IOL is being implanted in the back in situ. Also regarding the power, I would I would like to make a point here. The IOL is being implanted and optic captured, so we can either take a IOL of zero point 0.5 diopter because the effective lens position is getting relatively anterior, or else optic captured IOL like this, the same power would suffice.
We have Dr. Anish Srivastava sir with us. Sir, would
Yeah.
you like to give some comment?
Yes, yes. Uh, Very good surgery. And
Thank you, sir.
one comment is just by chance, today we had a meeting in the OT and
Mm,
got the opinion of the OT staff. After last 3 years, I've
mm,
been using hydro implantation, many thousand implantation. And
mm,
finally, we concluded that we
mm.
should stop it. Reason is it is
Yeah.
not as reproducible, as
Mm,
safe
mm,
as the visco implantation. In this, visco is going while loading, you are injecting the IOL wrapped in the visco. So it is not completely visco free,
mm.
and the overall time doesn't make any difference. When there is a question of quality, reproducibility, almost 100% sure that lens is going to open slowly, proper fashion. It will not going to touch the endothelium. It will not going to hit the posterior capsule. So even it takes 10 to 20 seconds extra, that cost is worth. So we decided today itself we will go by Visco from tomorrow onward.
Okay, sir. Very nice, sir. We have Dr. Bhupen Chaudhary with us. Sir, Dr. B.N. Chaudhary, sir.
Yes, yes, I'm here.
Good evening, sir.
How
Sir,
are
would you
you?
like to say a few comments?
Dr. Shwasta has rightly said that uh, this three-piece IOL should be placed in the sulcus, not these ardophilics and all.
Right,
So
sir.
it was a good presentation by Dr. Anurag.
Yes, sir.
Just I'm not getting a video. Anyway,
So,
yes,
any Dr. Sakib, any other person who would like to
Can we
comment?
implant single piece hydrophobic acrylic in sulcus?
So, Dr. Anurag, would you like to answer this question?
Sorry, ma'am. Please, can you repeat the question?
Implants
Single piece IOL in the sulcus.
hydrophobic acrylic in sulcus.
Hydrophilic acrylic in sulcus.
Hydrophobic acrylic.
No, ma'am. Those are also not meant to be placed in sulcus, ma'am. For the same reason, again, they'll be causing a posterior rubbing of iris. Their stability is a question mark. However, if we are able to get a good optic capture of the same, in case I understand if the three-piece IOL of a appropriate power is not available, if at all that happens. Uh, we need to have a good optic capture. We need to, but honestly, they are not supposed to be placed there.
Not supposed to. Why did you go for optic capture?
Ma'am,
Why did you simply implant the lens in sulcus only? Because routinely, do you do optic capture in every case?
no, ma'am. For the sake of the stability, though three-piece by itself would be relatively stable compared to a single piece.
You have specifically did optic capture in this case only.
No, ma'am. If in a case of
If the rent is big enough, how can you do a optic capture?
in the anterior excess margin, we have secured the case which I showed. The rent was eventually a bigger. Initially, it started with a smaller rent, but the IOL management, the rent got relatively large. So we captured the optic in the anterior excess margin, which eventually provides a long-term stability to the IOL, as if it is IOL placed in the bag itself. The effective lens position is almost the same.
Yeah. So effective lens position is all the same, and also the stability of IOL is there. So it is always a better idea to do optic capture if the rexus size is adequate and it can be done. So I think with this wonderful presentation,
One practical problem, which especially in government sector we face, that we don't have all the powers of three-piece IOLs available with us.
right, sir.
Mostly.
Right,
तो
sir.
usually होता क्या कि जो आप प्लान करना वही लेंस हमारे पास होते हैं. At the
Yes.
time we have to place those hydrophobic or hydrophilic IOLs in the sulcus. So are they really very much contraindicated, or they are tolerable that you can place them in sulcus?
So
Because
many
most of the
times
time
they
we have
don't
placed,
create any problem, but then sometimes they do. And especially sometimes there are many patients who come with secondary glaucoma, and then we see that IOL, single piece IOL is in sulcus, and that is causing this sort of problem. Or as Dr. Anurag said, UGS syndrome many times happen, where uveitis is also there along with glaucoma. So better to avoid, but as you said, sometimes there are limitations. Then otherwise, better to avoid.
If good vitrectomy is done, and checked also, don't leave it without checking. Check it with proper way, and then there will be least chances of uveitis. And even not one or two, many cases done by me and done by other surgeons, I have seen that they are lying quietly in the sulcus, whether they are hydrophilic or hydrophobic. I was also very much afraid, but sometimes you were forced to do. So
yes,
I have
we
done
know
also,
that.
and I have seen other doctors also, and they are all doing well. Those cases are not doing well where vitrectomy is not done well. So if the vitreous is in AC or section or iris is disturbed, then the glaucoma and continuous uveitis and so many problems, and finally eye is lost also.
Right.
Dr. Anil, do you use
Thank you, sir.
staining of vitreous to check that your
Trans-
vitrectomy is
Because
complete?
many times now you feel that you have done very well, but there are some
Cancer
cracks in the section,
Yes.
and they keep on hurting you by not only by disturbing the pupil, but by the continuous chronic uveitis also. So it is good practice to do
No,
at least where the vitreous is formed. It is very watery, very old patient, you can go fast, you can leave it. But in most of the cases, stain it.
stain it with Samsung, no?
Right.
So I think with the due permission and because timing is running, so we'll move on to next presentation and a nice discussion happening. Dr. Neetu, would you like to invite next presenter for this webinar?
Uh, I'm inviting Dr. Achal Tripathi, West Bengal. She's assistant professor in FMC, MBBS from KGMC, and she has done her MS from GSVM. She is an excellent anterior segment surgeon with more than 30 publications. And today she will present an interesting optic neuritis. So I invite Dr. Achal Tripathi to present her talk.
Good evening, one and all. Am I audible?
Yes.
Yes. Sure.
Is my screen visible?
No, your screen is not visible, Achal.
फिर से लगाया तो असल में डब्बा भी साथ में रखते ना तो समझ में
अच्छा ब्लूटूथ ऑफ हो गया.
एनके सिंह सर नमस्कार.
नमस्कार नमस्कार.
सर
आशुतोष कैसे हो?
ठीक है सर, एकदम बढ़िया एकदम बढ़िया.
Till the time screen is off, just talk to each other. Or we can call the next speaker if he's ready.
Okay.
If he's ready, next speaker can be
Yes. So, Dr. Neetu, you can, in the meantime, you call Dr. Indranil and Dr. Anchal. In the meantime, you re-log in, that it will help.
आवाज आ रही है?
Right.
कैसे आ रही है?
I mean, Dr. Indranil Shah to present advocating the use of intravitreal vancomycin infusion while doing PPV in acute endophthalmitis cases. He is an MBBS, MS, FVRS, FAICO, Associate Professor in Regional Institute of Ophthalmology, Eye Hospital, Sitapur. So I invite Dr. Indranil Shah to present his paper.
Thank you, ma'am. Good evening, everyone, respected seniors, my dear colleagues. Thank you, Dr. Shalini, ma'am, for giving me this opportunity to present here tonight. I'll just quickly share my screen first.
Yes, it's visible.
Thank you, sir. So, endophthalmitis is a diagnosis which none of us want to hear. It's something which the anterior segment surgeons, posterior segment surgeons, nobody wants to deal with such cases, but we are the ones who, at the end of the day, have to take care. So, on that note, endophthalmitis is an ophthalmic emergency due to its potential for significant visual morbidity and sequelae. Endophthalmitis leads to loss of vision due to irreversible damage to photoreceptors caused by the bacterial toxins and can be broadly classified as endogenous or exogenous. So, approximately 70% of cases are complications of intraocular surgeries, mostly cataract surgery, capsular or zonular surgical complications, wound leaks being the main risk factors. Management of endophthalmitis has evolved from old school enucleation to intravitreal antibiotics and now PPV. So intravitreal injection was the empirical choice, being vancomycin and ceftazidime, and this was called the silver standard, which by the 1980s was replaced by PPV, which was then labeled as the gold standard in the treatment of endophthalmitis. For a long time, the EVS study has been providing us the foundational framework and emphasizing vitrectomy only in cases for severe vision loss. Advancements in surgical techniques, evolving pathogen epidemiology, antibiotic resistance, and newer diagnostic methods have necessitated us to reevaluate our optimal treatment strategies. So vancomycin is considered to be the drug of choice for empiric coverage of gram-positive organisms, the most common cause in end-of cases. So we did this prospective study at our RIO, Sitapur Eye Hospital, and we just did a mild modification, a small modification, but with great impactful results, where we wanted to put vancomycin right in the infusion that we are using for the PPV in cases of endophthalmitis for and hoping for a favorable anatomical and visual results. So we took the institution review board permission. It was a prospective 1-year study. The inclusion criteria were patients who with endophthalmitis that could undergo a PPV. Exclusion criteria were those in whom PPV could not be performed, and in post-traumatic cases because of mixed flora, mixed organisms that one could get in these cases. So all patients underwent a 23-gauge 3-port PPV. The vancomycin solution was prepared in the OR by dissolving 1 gram of vanco in 10 ml of sterile normal saline and then dissolving 1 ml of this mixture in 500 ml of BSS. Silicone oil tamponade was instilled wherever required. So we had 26 patients. Age range was from 14 to 83, mostly males. 6 weeks and 6 weeks were defined as acute, where we see that was the most of our cases, where 67.5% cases were acute. Endogenous cases were 27%. Acute, the vision improvement in BCVA was markedly seen in all the 3 categories, as is seen in this graph over here. So these were a few cases, and as you can see how the wound was compromised, which led to this kind of an end-of presentation. This is the ultrasound pre-op and then post-op fundus image, where we had a remarkable vision recovery from hand movement to 6 parts. These are intra-op photographs where this was at the beginning of the surgery, and at the end of the surgery, this is how the fundus looked. And the vision improved from counting finger to 6/9. So this is a small video just to show the vitrectomy. After cleaning up the retro IOL debris, we are going in completely to clean up as much as possible. A little different from the EVS, where it was just to do the core. Now we are following in the EMS study, where it is to go in and do an aggressive vitrectomy, clean up as much debris as possible, and so that you can have better results. This is how the case looked at the end of the surgery with a proper cleanup. So, customized treatment. Our study confirms that tailored treatment protocols can lead to significant visual recovery in end-of cases. The EVS study, well, it held its good for a long time, but the newer research shows that earlier interventions are crucial and are demonstrated by beneficial effects of early PPV, which aids in bacterial load clearance and toxin removal. Aggressive response to emergency results in better visual gains and anatomical prognosis. The aggressive and prompt management approach at our institute supports this critical principle. Because we intervened with an early vitrectomy, we got a good vitreous biopsy to get PCR results. Small gauge vitrectomies are safe and have less collateral damage. Prophylaxis is the key. This point needs to be emphasized. The use of povidone iodine pre-op gives that patient 1 minute of your time to as a prophylaxis with the iodine before starting the surgery. The EMS study. So this is the multi-center Indian trial, where now the emphasis is shifting more towards inflammation, whereas the EVS study was relying only on vision, where we're looking at parameters like the cornea, the anterior chamber, iris, vitreous, and an inflammatory score is generated. Less than 10, go for intravitreal injections. 10 or more, plan a vitrectomy. Newer antimicrobial strategies, intravitreal vancomycin infusion in cases of PPV causes a deeper penetration of the antibiotics into the area. So as you're cleaning the debris, your fluid is with the antibiotic loaded fluid is cleaning up the affected area. Vancomycin is effective against most gram-positive bacteria, also MRSA, and it's a glycopeptide antibiotic inhibiting the bacterial cell wall protein synthesis. It's instantly, vancomycin instantly during PPV in the infusion gives the highest concentration at the target site. Nowadays, most therapies are more target oriented and seem to have a better for the circulation of the antibiotic in the eye during surgery. In our study, we used silicone oil as a tamponade in 6 cases because there was associated retinal tears or detachment. Silicone oil being an inert media does not support microbial growth, and was also effective in separation of multiple endophthalmitis causing organisms. The technological advances of small gauge PPV seem to afford visual benefit with more rapid healing, less discomfort, and an acceptably low incidence of collateral damage. So, endophthalmitis is a desperate diagnosis and it calls for strong measures, an anatomical and visual emergency which needs to be addressed aggressively. A modified PPV, in terms of having an intravitreal vancomycin infusion, ensures a better drug penetration and sounds a promising tool. It debulks infective load with wider exposure of potent antibiotics such as vancomycin, promising anatomical and visual results. These are my references. Thank you.
Dr. Saha, you didn't show your study between with a PPV without vancomycin and with vancomycin. You
Yes, sir.
Was there any comparative study done between the two?
Sir, this is one study that we have done. There is another, because this one had a very few patients of
How
just
many cases were
26.
how many cases you took without vancomycin and how many with vancomycin?
So,
PP,
sir, these all 26 cases we took with vancomycin infusion, sir.
no, then how? What was your compare? How do you compare it? Do you,
Yes, sir. So we
how do you
haven't.
compare it? That is it beneficial without with by using vancomycin, or it is just your assumption?
So, sir, we had been doing conventional vitrectomies earlier, where we were not using vancomycin infusions, and at the end we were injecting intravitreal antibiotics. So, this is a study which we started. We have another paper in the pipeline where we are comparing the both. But the one advantage that we saw was because there was a much more cleaner retina at the end, and because there was a better antibiotic, which we feel was a better antibiotic penetration, we saw better visual results and a faster improvement versus the conventional vitrectomy that we were doing with just a normal PPV.
So you know more studies to really come out that vancomycin is definitely
Definitely, sir.
beneficial. Are
We
you
need
using our a question
definitely,
to
sir. We need to
our
compare
audience?
the
Are
two.
you using some fluid while doing the surgery?
I'm sorry,
Uh,
sir. I missed that, sir. I could not get it.
a question to the audience that are we are they regularly using antibiotic in the fluid while doing the surgery, normal surgery without the thermometers? And
Whether
have
they are
they
using
found
an
any usefulness
infusion,
or
No,
that
sir. In
yes, infusion?
normal
What
cases, we are
antibiotic
not
they are
using.
using and
In the normal
not
cases, we
using?
are not using
I
antibiotics,
think
sir.
2 3 years back there was a lot of trend. There was 2 3 years back there was a lot of trend of using antibiotic in your infusion. Dr. Anil, you may agree with this. That
see,
there was a lot
in
of stress on using antibiotic in your infusion,
see in
in
end
your
of
fluid.
thermitis, Dr. Nulan
No, not in
saying that
an
in
dermatologist,
some cases
just
he is using
prophylactic,
antibiotic,
prophylactic.
in some cases he doesn't use. But what I feel that it should be used in every case, and most of the doctors are using antibiotic after vitrectomy in every case in bolus form, not in infusion form. And I don't
Hmm.
believe that it will make any difference whether it is in infusion or in
Yes.
bolus. And there is no study to substantiate this concept that infusion is going to improve it. So Dr. Indranil will work
That is what I
more
meant.
to substantiate this stand, that how he feel that it will work better than the bolus antibiotic.
So, sir, we got this idea after going through a certain studies on endophthalmitis, where there were studies where the surgeons have used vancomycin infusion and gotten better results. And now there are cases where they're reporting betadine infusions to get the same desired results. The idea is very simple, sir. When you're doing it, it is like you're going in with your vacuum cleaner. You're cleaning the mess up, the debris, the infective load. and right behind as a lavage, the fluid which is loaded with antibiotics is coming in. So it is like kind of doing a vitreous lavage and getting rid of the infective load. And there are published studies of intravitreal vancomycin infusion, and very recent literature are talking about betadine infusions, which we haven't yet tried at our center. But yes, I agree to the point that we need larger numbers for comparison versus an intravitreal vancomycin infusion versus a bolus dose of antibiotics to substantiate this point.
Betadine is so toxic to endothelium that if by mistake, if you wash the AC for even for 5 seconds and then wash it thoroughly, next day you will find the whole endothelium is gone.
Sir, it is used in a diluted thing of
is the answer only.
We haven't used it yet, but the published literature talks about 0.025% in a in the infusion. We haven't used it yet, but there are literatures that is coming out now with betadine infusions.
I have seen its effect, and it is so toxic that within 5 seconds it was
Yes,
washed.
sir.
And
That's why we haven't used it yet, sir. We haven't used it at our center yet.
So,
in fact, when we are
that this is a highly dangerous item for the inside the eye, particularly for the endothelium.
Yes, sir.
Betadine is very toxic to endothelium.
Yeah, that is the reason we haven't used it at all.
It should not be used in AC.
In fact,
even in diluted form.
Yes.
In fact,
inside the eye should not be.
In fact, when we are when we are washing with betadine
Dr.
before starting the
I
surgery,
want to ask
I
one
think
question. Am
Yes,
I audible?
Yes, ma'am.
I have seen recently, unfortunately, I must say, one of my case developed endophthalmitis. Okay, I referred that case to institute. They did pars plana vitrectomy. They gave intravitreal injections. After that, I don't know why they left silicone oil in the vitreous cavity. And what they are saying ki that silicone oil is given just to prevent the growth of bacteria, because silicone oil is considered to be bacteriostatic. You know. So for
Yes,
the
ma'am.
first time, I came to know ki after PPV in endophthalmitis cases, people, vitreoretinal surgeons introduce silicone oil in the vitreous cavity. So is it really needed, or this logic of bacteriostatic
So, ma'am,
property
yes,
of
silicone oil is silicone. Thank you, ma'am, for the question. Yes, ma'am. Silicone oil, like you saw in our study also, we have used it in 6 of our cases. Well, because there was an obvious need because there was an RD and there were tears there. Having said that, silicone oil is an inert bacteriostatic media, and it serves as a good tamponading agent, and if not anything, to hold the eye together.
Suppose there is no RD, there is nothing happened during vitrectomy, then silicone oil should be injected inside to prevent the bacterial growth.
I would, if the retina is intact, if there's no tear, no detachment, I would hold back on the silicone oil, ma'am.
Hello, Dr. Indranil.
Hello, ma'am.
Hello.
Hello, ma'am.
Yes, sir.
Dr. Atul here.
Dr. Indranil, it's Dr. Alok here. Hello.
Dr. Alok.
Yeah. My question is that you have been using this infusion of vancomycin. During the closing of the surgery, are you giving a bolus of intravitreal vancomycin?
No, sir.
Because during the procedure, you have used the vancomycin as an infusion. When you are closing the surgery, so are you giving that a bolus injection of that vancomycin or not?
No, we are not doing that, sir.
Achha, you are not giving at all?
No, sir.
So then we will definitely like to see the comparative result whenever you are going to publish it.
Comparative result has not been done. Study has not been done.
Ma'am, for your answer, ma'am, Dr. Atul here. For your answer of endophthalmitis, the use of silicone oil in the case of endophthalmitis, the idea is not new. I think Dr. Dinesh Talwar sir is using from the last 20-25 years.
Yes, and agree, sir.
Yeah,
yes.
And the concept is to limit the cavity with the minimal space for the bacteria to grow. And we are doing this the use of silicone oil when we are not able to see the retina. When the case is so bad that we are not able to complete the vitrectomy, we are not able to see the retina, then we just fill the silicone oil, and after that, after some time, we will do the optical vitrectomy. So it's not a new idea. It's a ongoing idea, and if everybody is doing who's dealing with the endophthalmitis, really bad cases, not for the simple cases. And it's not necessary that
because being an anterior segment surgeon, this was for the first time I saw somebody has injected silicone oil in the vitreous cavity. So I just thought,
nobody will put the silicone oil in a simple case. Everybody will. Silicone oil is the last resort. So I just want to ask from Dr. Indranil, the case he has shown, whether you have used the intravitreal antibiotics previously or directly you have gone for the vitrectomy, because the case was looking quite clear. Even with the counting finger vision, the case was looking quite clear. So whether you have tried in this type of cases, just intravitreal antibiotic, take out the sample, send for the gram stain culture, KOH, or you have you are going directly for PPV in every case.
Sir, usually we see how bad is the infective load, sir. In these ones, we have been going directly for the PPV cases, sir.
No, in your case, the vitreous was looking quite clear.
Yes, sir.
Vitreous was looking quite clear.
Sir, the video that we saw.
Yeah.
Yes, sir. So, sir, if you see the video, it has flipped between the anterior segment and the posterior segment. So there was a little lag between the two. The photos that I showed in before the video happened was what the structure was before at the time of vitrectomy, sir.
Okay. Because I have seen in my experience, I have seen that if you give the antibiotic first, take out the culture, go for the 1 or 2 injection 48 hours apart, and if required, if you go for the vitrectomy, the results are much better than directly going for the vitrectomy.
Yes, sir. So that was what we were doing quite some time back, sir. We still are in patients who say that they cannot afford a vitrectomy. But what we found, sir, was the faster we removed the infective load, it got us better visual and anatomical results here, sir.
This is a very debatable question because surgery is a double-edged sword.
Yes.
This is a very debatable question that you are going inside the eye, which is already inflamed, and you are saying that you will take out everything. You cannot take out everything because pars placata, so many nidus are there. So, sir, I'm not saying you are wrong, but my experiences previously 5, 6, 7 years back, I was directly jumping into the vitrectomy, but now I have changed my idea that first I will try. If the case is not very bad, within a day or two, if the patient is coming, I'll go for the vancomycin injection and take out the culture, gram stain, KOH. See, 48 hours, I'll give, if KOH negative, again I'll give vancomycin, and this time I'll go for the DECA also. If the case is not improving, then third time I will go for the vitrectomy. And I have not seen from the last 4 years, I have dealt hardly 5 or 6 cases, but this approach is much better than my previous approach. Okay, so
thank you, sir. Thank you, sir, for your input. Now our next speaker, Dr. Achal Tripathi.
Is my screen visible now?
Yeah, its screen is visible. You can carry on.
Apologies for earlier inconvenience. Good evening, everyone. Grateful to Dr. Shalini ma'am, who is also my mentor, and UPSOS for giving me this opportunity. I'm presenting here an interesting case of facial on coup de sabre presenting with optic neuritis in the contralateral eye. So the patient was a 31-year-old female And she presented with paleness, progressive blurring of vision in her right eye since 25 years. And there were no episodes of sudden vision loss or neurological disorders or any history of trauma. So when the patient was examined, you can see that there was a band-like diagonal line over left forehead, and it was extending to right upper lid, along with eyelid retraction, madarosis in the same eye, and thinning of eyelid margin also. So this is the band-like diagonal line which was extending over the scalp also. On ocular evaluation, her right eye vision was 1/60 and left was 6/6. I would emphasize here that her right eye vision was less and we were seeing the lesion over her left side. Now, the temporal sectoral iris atrophy can also be seen in the left eye, and on fundoscopy, we found optic atrophy. So her MRI brain in orbit was normal except the optic nerve atrophy part. The patient was sent for dermatological opinion and she was diagnosed as a case of linear morphea. So in cases of linear morphea, so it is a type of localized scleroderma that involves head, face, and extremities. So in such cases, the involvement of eye is usually ipsilateral. Ocular involvement is very, very rare, and even if it occurs, it is usually ipsilateral. And to our knowledge, there has been no case report which has reported that contralateral involvement has occurred. So this encode saber term is a French term, and it is it's used to describe the linear scar due to its resemblance with a wound from a sword. So ipsilateral eye was re-evaluated because there was no such case report previously in the literature. So the ipsilateral eye was re-evaluated. It was found to be NAD. Also, in our case, the MRI was normal. Usually in such cases, MRIs also show abnormalities. So finally, a diagnosis of facial encode saber with contralateral optic atrophy was made. The optic atrophy was a resultant of the optic neuritis that may have occurred over a period of 25 years. So this localized scleroderma is not purely cutaneous and it involves other tissues also, and ocular involvement, though rare, can occur. So the clinical importance of this case is that the ipsilateral lesions are ocular involvement is usually ipsilateral, but in this case we saw contralateral involvement, and the ocular findings may be subtle. As we saw in this case, it was a delayed finding, and MRI may be normal despite significant ocular pathology. The proposed pathogenesis for this disease is autoimmune or inflammatory, and the eyelids and extraocular muscles are involved in fibrotic inflammation. So the key message for this case, although this was a lost case, the case was not diagnosed for over 25 years. So we should maintain high suspicion for ocular involvement in all morphea cases, and we should alert dermatologists that when they receive morphea cases, they should send the patient for mandatory ophthalmic evaluation. And obviously, it requires multidisciplinary management, and early detection and follow-up is essential to prevent irreversible vision loss. Thank you so much.
That was a good presentation, Dr. Achal Tripathi.
Thank you, sir.
Hello. Achal, Dr. Achal, it's Alok here, Dr. Alok.
Yes, sir.
You are presenting here a scleroderma. Did you evaluated the anterior segment regarding the dryness of the eye? Because most of the time scleroderma often presents with your keratoconjunctival
Yes, so the patient did not have sicca at this stage. The most prominent finding in our case were the sectoral iris atrophy and the optic nerve atrophy.
And no other involvement, such as it also undergoes a Raynaud phenomena and a polyarthritis joint pain. Nothing was there. Just a single.
No, it was only a case of facial morphia.
Okay.
No other systemic involvement was there. Only a case of facial morphia.
So, what was the treatment? Then you planned for it? Anything?
This was already a lost case on our part. The patient was sent for dermatological treatment. There, the patient was kept on topical treatment as well as on oral treatment such as corticosteroids and methotrexate.
Immunosuppressants were used for that.
Immunosuppressants, yes.
Okay. Nice presentation.
Thank you, sir.
It's a very rare case with optic atrophy in contralateral line rather than ipsilateral. So it is a very rare presentation and very nice. Thank you, Dr. Achal. Now I am inviting my next speaker, Dr. Atul Dhawan, who is a senior ophthalmologist and vitreoretinal surgeon based in Kanpur, currently practicing at ASGI Hospital in Shastri Nagar. So now I invite Dr. Atul Dhawan to present his talk on 7 commandments of inverted internal limiting membrane flap surgery. Dr. Atul Dhawan. I think he has kept his video on mute.
Yeah, can you see my video?
Yeah. Okay, it's visible.
Oh my God.
You can start your talk.
One second, ma'am.
Okay.
ऐसे हो रहे शेयर करना शेयर स्टॉप शेयर one second. Can you see, ma'am?
Yes, I can see. Screen share.
Yes, it's visible. Yes.
Thank you everyone for this opportunity. And today I'm going to talk about one surgery which is very glamorous in VR, because there is no blood, no hassle, and the name is macular hole surgery. Today I'll discuss about only large macular hole surgery with the inverted ILM flap, which is very, very common nowadays. We will not talk about the definition of the macular hole and the pathogenesis, anything. We'll just directly jump over to this large macular hole surgery with the inverted ILM flap. So we have to find out 7 answers. The 7 questions are: what should be the pre-op assessment? The second one is the PVD induction, posterior vitreous detachment induction. The third one is ILM staining. Fourth is the flap creation. Fifth is the fluid air exchange. Sixth is drying of cavity. Seventh is post-operative care. Now, this is a pre-op assessment. You can see this case I have done 3 days back only. And this is -15 diopter young lady. And the patient is having 550 micron hole. This is high myop lady, large macular hole because it is more than 400 micron. So we have to operate this case. So first thing, many criterias are there. Many criterias are there that we can take. One is but what I usually take is the minimal hole diameter. Minimal hole diameter means the diameter of the hole which is minimal in the horizontal direction. In this case, the minimal hole diameter is 550. So I have decided to go for the surgery, inverted flap surgery. Pre-op assessment, is only minimal hole diameter. The second one is the PVD induction. How I do the PVD induction? Just after the core vitrectomy, just stain the ILM, just stain the vitreous with triamcinolone and do the PVD induction like you are taking out a rasgulla from a bowl with the help of a spoon. Just see this. High magnification. Just take your cutter at the disc, pull it. You can see the vitreous is stained and it is coming out. It is coming out from the margin of the disc. This is the PVD induction. The third question is ILM staining. How to stain the ILM? We have to stain the ILM with the help of the brilliant blue. How I am staining the ILM? I am staining the ILM under air, around 15 to 20 drops, pouring just over the posterior pole with the help of silicone tip cannula, in which I have removed the silicone tip because I don't want that extra jet should be created during the injection of the BBG and which can cause any tear on the posterior pole. Next one is the flap creation. Flap creation is the principle of ILM flap. This is very important. First of all, how much big flap? The second is how to make a flap. And the third one is how to keep the flap over the hole till the last part of the surgery. We will find the answers one by one. If we'll go to our 12th standard physics, and we will take the two sides, the ILM and the second one is the retina, as a two glass plate which are separated by a fluid. Then the force which is required to separate the upper plate from the lower plate is equal to the 2 Ta upon D. Now, what is A? A is the surface area. So, if A is large, means surface area is large, then the natural force required is higher. That means if your flap is large, the natural force required is more. Because of this, we have to make a large flap. The second question is how to create the flap. This is show the video. These are 3 layers of retina. Brown one is RP, the red one is neurosensory, and the blue one is the ILM. How to make the flap? One imaginary line, 200 degrees circumferential, give small necks and connect them from one side to other side. Now, how to place the flap over the hole? Just remove it from one side, hold it slowly and put it over the hole. This is just a description. I'll show you the surgery now. Now, because I was there in Chennai for 15-16 years, so I usually call this dosa technique. How to place the flap over the hole. You can see placing the flap over the hole is like dosa, making a dosa. So I have called this a dosa technique. Now, the question number 5 is fluid air exchange. How to keep the flap over the hole till the last part of the surgery. You can see in this video, I have put the fluid in the bowl. I will tilt the bowl towards the disc side, and the movement of the fluid will cause the ironing out of the flap over the hole at the last part of fluid air exchange. Just see, I am pouring it from one side. I am tilting towards the disc side because the flap is from temporal to nasal. Then I'll take out this flap. The movement of this fluid will cause the ironing out the flap over the hole at the end of fluid air exchange. Now we'll go for the live surgery. This surgery I have done day before yesterday. Now you can see this is how I am doing. I am tilting the eye toward the disc side. You can see the flap over the hole and it is ironing out. Just see, it is ironing out this blue flap. You can see the blue flap ironing out over the hole. Again, I am showing this. Just tilt the eye towards the disc side. This is left eye. And you take out the fluid. This movement of the fluid will cause the ironing out of the flap over the hole. The last one is the most important part, is drying of the cavity with the help of the passive fluid air exchange. Now I am taking out the fluid by the circumferential movement of the passive suction cannula just away from the margin of the flap. This drying of the cavity will keep the flap over hole in the long run. In fact, most of the people have seen, if the flap is there for 24 hours, the hole will close. Post-operative care, as soon as I finish the fluid air exchange, I keep the patient in the prone position. I never send the patient to home. I keep the patient in the post-operative room for the 6 hours. After that, the patient will go, and the simple instruction is just to see the toenail every time, every moment when you are walking. Otherwise, be in prone position. This should be there for the next 5 days. 1 day is enough, but 5 days just for the precautionary purpose. All of this exercise just because our aim is not just the hole closure on the OCT, but the functional result also. So our aim is minimal intervention, minimal surgical trauma, easy and reproducible surgery. Thank you.
Thank you, Dr. Atul Dhawan, for such a nice presentation, and
It's very nice. Yes.
you described each and every step very nicely, and even you compared all those steps with our day-to-day routine work like dosa technique, and it was with, you can remember if you correlate such things with common activity, routine activity. So any questions or input from audience side?
डॉक्टर धवन
In fact,
showed very nicely. और बहुत अच्छे से दिखाया आपने से प्लेस करते हैं you
Although I'm not posterior segment surgeon, but I like the
हमारे
way
दिमाग से
you
बात की
presented the topic.
in fact,
Dr.
ma'am,
Indrajit?
in fact,
Yes.
ma'am, this surgery I have developed in the last 13 or 14 years, because it's not, the surgery looks easy, but the steps, every step is very complicated. Till you don't know what is the exact way to do the each and every step. So we have given a lot of time on this topic. So I can say,
it's your expertise now.
Pardon, sir?
It's your expertise now, Dr. Dhawan. Well done. Very nicely you have developed this.
Thank you, sir.
Now I take the permission of our senior members, and I'm very thankful to all my speakers and participants, our guests. And now I call upon the meeting. Thank you and good night,
Thank you.
everyone.
Very nice meeting. Thank you.
Good night. Good night. Very good program.